Welcome to this training on morbid obesity. Today we'll review what this diagnosis means, common clinical considerations, when a provider query may be appropriate, and important care planning concepts for skilled nursing residents. Morbid obesity, also known as Class 3 obesity, is generally defined as a BMI of 40 or greater, or a BMI of 35 to 39.9 with serious obesity-related conditions. But obesity is more than a BMI. It is a chronic disease that can affect multiple body systems and may increase the complexity of resident care. When we think about morbid obesity, it's important to recognize that it can affect much more than a resident's weight. Some residents may become short of breath more easily, have decreased activity tolerance, experience sleep apnea, or require CPAP or BiPAP support. It can also impact mobility. Residents may have difficulty walking, require additional assistance with transfers, use bariatric equipment, or need a mechanical lift to ensure safe movement. In addition to respiratory and mobility concerns, morbid obesity can affect several other areas as well. Residents may be at higher risk for skin issues, such as skin fold irritation, moisture-related skin damage, or pressure injuries. You may also notice that residents tire more easily, have limited endurance, or require more assistance with daily activities. It's also common to see conditions such as diabetes, hypertension, heart failure, or edema occurring alongside obesity. So why does this diagnosis matter? Morbid obesity can affect many aspects of a resident's health and daily life. It may impact mobility, transfers, respiratory status, skin integrity, participation in therapy, and overall quality of life. It can also increase the risk for medical complications and influence the resident's plan of care. So, when should we consider a provider query for morbid obesity? Start by asking yourself 3 questions. First, does the resident meet the obesity criteria? Second, is obesity affecting the resident's health, function, or quality of life? And third, is obesity being monitored, treated, or care planned? If the answer to these questions is yes, and the diagnosis is unclear or not documented, a provider query may be appropriate. Let's look at an example. In this case, the resident has a BMI of 44, diabetes, uses CPAP at night, requires a 2-person assist for transfers, uses a bariatric wheelchair, and is receiving both physical and occupational therapy services. Would a provider query for morbid obesity be appropriate? In this situation, the answer is likely yes. The resident meets the obesity criteria, and obesity appears to be affecting the resident's care, function, and treatment plan. Once morbid obesity has been identified, there may be several interventions in place to help support the resident's health and function. Depending on the resident's needs, this may include nursing monitoring, therapy services, dietary involvement, and the use of specialized equipment such as bariatric beds, bariatric wheelchairs, mechanical lifts, or CPAP and BiPAP devices. The goal is to help reduce risk, support function, and promote the highest practicable level of well-being. Now let's look at a sample care plan. As you review the example, notice how the care plan reflects the resident's individual needs and the potential impact of morbid obesity on daily function and overall care. Care plan focus areas may include mobility and transfers, fall prevention, skin integrity, respiratory status, nutrition and weight management, therapy participation, and maintaining the highest practicable level of function. As a final takeaway, remember that morbid obesity is more than a BMI. If documentation is unclear, ask yourself whether the resident meets the obesity criteria, whether obesity is affecting care, and whether it is being monitored, treated, or care planned. Under PDPM, morbid obesity contributes 1 NTA point when appropriately supported and documented. Thank you for participating, and that concludes our presentation.